So we're now in an era of personalised medicine, and we have been for the last 5-6 years in lung cancer. It's a very exciting time to be treating lung cancer, but with exciting times brings challenges, and the key thing is going to be about testing. And we know, again, we've talked about small biopsies in lung cancer, we've talked about circulating DNA and trying to pick up certain actionable mutations. And we know that non-small cell lung cancer is not just one big disease. That's why we've been treating it so poorly, because we're treating everybody in the same way. If we pick out these small groups of patients who we know can respond really well to one drug, we know these are very clean cancers occurring in non-smokers, and if we can give them one drug which really works very well, because we know that that is the problem, or that's the gene that goes wrong which is driving the cancers, we can then give them a targeted drug to overcome that whole cycle of malignancy and progression of disease. These drugs are also very well tolerated generally, so they're better tolerated than chemotherapy. The challenge is this is a very small part of the big pie of non-small cell lung cancer, and therefore if you don't look, you won't find. So you may have to test 50-60 patients before you get your first new actionable mutation. And we heard in this meeting this year that RET fusion is another target, but it's only representing 1-2% of patients. But if you're that one person and you do not get that drug, that will be a tragedy, because these are response rates with 60-80% response rates to these very targeted agents. So we heard about RET fusion, so that's another little small slice of the pie. The MET amplification, RET fusions, the MET amplifications and the fusions that we've seen is another small pie, and NTRK is another target. So these are all small proportions of non-small cell lung cancer, and often occurring in very similar type of non-smoking patients. And we know that smoking cancers are, cancers in smokers are very different to that in non-smokers. We know there's very widespread genomic change in smokers compared to non-smokers. And so picking up this small proportion of patients is only going to be possible if we reflex test everybody. So the more you test, the more you'll find, and it's all about the diagnostic pathway and how we're going to get either that tissue or blood, hopefully in the near future, to those very specialized genomic hubs who have accreditation. We know the quality standard. These are not tests that can be possible in every even cancer center, never alone every hospital that treats lung cancer. So the challenge is getting that whole process streamlined, getting that biopsy to be fixed in a way which is genomically friendly, and the DNA is preserved. And we heard today that the national genomic hubs are there, and it's a great plan. However, the whole process has been very fraught. It has been difficult to implement, and we're still way away, 2 years away from having that paradigm where I have a biopsy from a patient at, say, Leicester, and 2 weeks later I get a genomic report telling me which patients have an actionable mutation. So there's a lot of work to be done, but small steps really, I think, before we can actually identify those small number of patients which really need that drug.